Effective lifestyle interventions for GPs to recommend by the Public Health Collaboration, presented by Samuel Feltham, the Director of the Public Health Collaboration. References for this presentation can be found on the PHC website at www.phcuk.org/ref1. And if a slide has a reference, the reference number can be found in the bottom right hand corner. I'd like to start off by answering the question, who is the Public Health Collaboration? We are a non-profit organisation dedicated to informing and implementing healthy decisions that is made up of 12 doctors of varying specialities, mostly working within the NHS. We also have public members from around the world that support our efforts to fulfil our mission. Today we'll be covering 3 points. Number 1. What are current healthy eating guidelines? Number 2. How can healthy eating guidelines be improved? And number 3. What could be a more effective solution? Current healthy eating guidelines from the NHS are called the Eat Well Guide and are presented in this diagram. The Eat Well Guide itself is summarised into these 7 points. Number 1. Eat at least 5 portions of a variety of fruit and vegetables every day. Number 2. Base meals on potatoes, bread, rice, pasta or other starchy carbohydrates, choosing whole grain versions where possible. Number 3. Have some dairy or dairy alternatives such as soya drinks, choosing lower fat and lower sugar options. Number 4. Eat some beans, pulses, fish, eggs, meat and other proteins, including 2 portions of fish every week, one of which should be oily. Number 5. Choose unsaturated oils and spreads and eat in small amounts. Number 6. Drink 6 to 8 cups or glasses of fluid a day. Number 7. If consuming foods and drinks high in fat, salt or sugar, have these less often and in small amounts. On the face of it, this advice might seem like common sense. However, the problem is that as a nation we have generally been following this advice for the past 20 years, yet have worsening public health year upon year. The latest National Diet and Nutrition Survey published in 2014 showed that our actual diets are incredibly close to recommended dietary intakes. Our fruit and vegetable intake is 1 portion shy of the recommended 5. Our red meat intake is just 1 gram over the recommended amount, and our total calorie intake is, on average, 383 calories below the recommended intake. And despite the UK population generally following these healthy eating guidelines, adult obesity is at 25%, childhood obesity is at 12 to 25%, pre-diabetes is at 35%, and type 2 diabetes is at 6%. And this costs the NHS £16 billion per year. So, what on earth is going on? To put it bluntly, current healthy eating guidelines are incorrect and are quite possibly one of the major contributors to the UK's dire public health statistics. They need to be dramatically improved to reflect the scientific evidence and updated as quickly as possible in order to turn the tide on public health. In our report, Healthy Eating Guidelines and Weight Loss Advice for the UK, we published in May 2016, we outline 3 areas of concern. Number 1. The avoidance of foods because of saturated fat content. Number 2, the dietary reference value of no more than 35% total fat. And number 3, the quality and quantity of carbohydrates. So let's start with concern number 1, the avoidance of foods because of saturated fat content. NHS Choices says that eating a lot of saturated fat can raise cholesterol levels in the blood, and having high cholesterol raises your risk of heart disease. This is still the advice from the NHS across the board, despite several meta-analyses over the past decade showing the contrary. Firstly, In July 2003, the Harvard School of Public Health published an analysis in the BMJ of 43,732 people, concluding these findings do not support associations between intake of total fat, cholesterol, or specific types of fat, and risk of stroke in men. Secondly, again, the Harvard School of Public Health published an analysis in the American Journal of Clinical Nutrition in March 2010 of 347,747 people, concluding intake of saturated fat was not associated with an increased risk of coronary heart disease, stroke, or cardiovascular disease. Thirdly, the Fred Hutchinson Cancer Research Centre published an analysis in the European Journal of Nutrition in July 2012 of 74,071 people, finding that observational evidence does not support the hypothesis that dairy fat or high-fat dairy foods contribute to obesity or cardiometabolic risk, and suggests that high-fat dairy consumption within typical dietary patterns is inversely associated with obesity risk. Fourthly, the University of Cambridge in March 2014 published an analysis in the Annals of Internal Medicine of 643,226 people, concluding current evidence does not clearly support cardiovascular guidelines that encourage high consumption of polyunsaturated fatty acids and low consumption of total saturated fatty acids. And finally, the University of Toronto in August 2015 published an analysis of 339,090 people in the BMJ, concluding saturated fats are not associated with all-cause mortality, cardiovascular disease, coronary heart disease, ischemic stroke, or type 2 diabetes. One of the most worrying aspects of the advice to lower fat consumption, and specifically saturated fat, was an analysis published in Open Heart in February 2015 that looked at the evidence available up to 1983, when restrictions on fat consumption were first introduced. It concluded that dietary recommendations were introduced for 220 million US and 56 million UK citizens by 1983 in the absence of supporting evidence from randomized controlled trials. And so, in light of this scientific evidence, the public health collaboration suggests that the UK stops recommending the avoidance of foods because of saturated fat content in order to focus on the consumption of food in its natural form, however much saturated fat it contains. Our second concern is in regard to the dietary reference value of no more than 35% total fat. As a nation, our current total fat consumption is actually almost identical to this recommendation of no more than 35% total fat at 34.6%. Again, NHS Choices says too much fat in your diet, especially saturated fat, can raise your cholesterol, which increases the risk of heart disease. This statement is not backed up by any scientific references on the NHS Choices website and is strongly contradicted from the evidence presented in our first concern, creating some terribly flawed circular logic. On the same page on the NHS Choices website, it links to a food fact sheet written by the British Dietetic Association that says, "We all need some fat in our diet, but eating too much of any fat makes us more likely to become overweight." The main concerns that the NHS and BDA seem to have in regard to eating more than 35% fat are the possible increased risk of heart disease and becoming overweight. However, in February 2016, an analysis was published by the University of Oslo in the British Journal of Nutrition, finding that, compared with subjects on low-fat diets, subjects on low-carbohydrate diets that are approximately 65% fat experience significantly greater weight loss, greater triglycerides reduction, and greater increase in HDL cholesterol after 6 months to 2 years of intervention. Despite this rather compelling evidence, the NICE guidelines for weight loss are still recommended a calorie counting low-fat diet. And because of these differing views, we at the PHC searched the scientific literature for all published randomised controlled trials comparing low-fat diets of less than 35% fat to low-carb diets of less than 130 grams of carbohydrate per day. 54 published RCTs qualified, which showed that, on average, low-fat dieters were advised to eat 50% carbohydrates, 30% fat and 20% protein, and were recommended to always count calories. And out of those 54 trials, 5 showed that following the currently recommended low-fat calorie counting diet resulted in greater weight loss. However, none showed a statistically significant greater amount of weight loss in comparison to low carb. On the other hand, low carb were advised to eat on average 10% carbohydrate, 65% fat and 25% protein, and were recommended not to count calories and to eat as much as they needed. And out of those 54 trials, 47 showed that following an ad libitum low carb diet resulted in greater weight loss, with 27 of those showing a statistically significant greater amount of weight loss in comparison to low fat. 2 of the trials showed the same weight loss. Also, despite low fat recommending to count calories and low carb recommending not to, the 2 different arms of dieters ate the same amount of total calories. Finally, the low carb dieters showed 3 times more statistically significant health outcomes other than weight loss compared to the low fat dieters. Therefore, according to the most reliable form of nutrition science we have available, advising an ad libitum low-carb diet for weight loss is more effective at lowering weight and improving other health outcomes than the current NICE guidelines of following a calorie-counting low-fat diet. Which begs the question, why aren't we primarily recommending low-carb diets for patients who want and need to lose weight and become healthier? And so, in light of this scientific evidence, the Public Health Collaboration suggests that the UK remove the recommendation to eat no more than 35% of total calorie intake from fat. Instead, recommendations should focus on the health benefits of eating food in its natural form, regardless of how much fat it contains. The third concern of the PHC is in regard to the quality and quantity of carbohydrates recommended. This is because well-managed blood glucose is of paramount importance in maintaining good health, especially in a population such as the UK, where type 2 diabetes and pre-diabetes are rapidly increasing year upon year. People who are obese are often also insulin resistant, which means that their body is unable to respond to insulin, a hormone that transports glucose from the bloodstream into the tissues. This results in blood glucose levels rising, leading to the pancreas secreting more insulin. This is why increasing insulin levels correlate with increasing body weight, as does the rise in the level of type 2 diabetes. This is because high insulin levels promote the accumulation of fat stores, particularly in the internal organs, and this contributes to the development of type 2 diabetes. And what macronutrient causes the highest secretion of insulin? That's right, carbohydrates, which is currently the vast majority of the healthy eating guidelines from the NHS. Carbohydrates can either be naturally found in food as sugar or starch, such as fruit, rice and potatoes, or can be artificially added, such as refined cereals, chocolate bars and fizzy drinks. However, a diet that does not rapidly increase blood glucose and does not provide too much carbohydrate to the body will help reduce the risk of worsening insulin resistance and can actually improve it. This can be achieved with a low glycemic index diet, which has been shown to reduce the risk of type 2 diabetes. The glycemic index, or GI, is a scale out of 100 based on how much the carbohydrate in a food increases your blood glucose compared to pure glucose. Above 70 is high, 55 to 69 is medium, and below 55 is low. Foods that are mostly carbohydrate can affect blood glucose vastly differently depending on their GI. A potato has a high GI of 82, Rice has a high GI of 73, whole wheat bread has a medium GI of 69, and an apple has a low GI of 36. Now, given what we've learnt about blood glucose and insulin, recommending foods with a high GI, as the Eat Well Guide does, by advising the public to base meals on potatoes, bread, rice, pasta, or other starchy carbohydrates, is illogical and opposite to what should be recommended in order to halt the ever-increasing rates of obesity and type 2 diabetes. Although the glycemic index is a useful tool, it does have limitations, as it only looks at the immediate blood glucose response. A useful extension of the glycemic index is the glycemic load, which accounts for the quantity of carbohydrates as well as the quality by using the glycemic index itself. You can work out the glycemic load of any food by using this simple formula. So when you compare foods that have a similar GI but differing amounts of carbohydrate in them, you get rather different glycemic loads. For instance, a 100 gram of whole wheat bread has a GI of 69 with 39 grams of carbohydrates, and so has a high glycemic load of 27. And a 100 gram portion of watermelon actually has a higher GI of 72 with 7 grams of carbohydrates, but has a low glycemic load of 5. Meaning that although watermelon can initially raise blood glucose slightly higher than whole wheat bread, the whole wheat bread will keep it there for longer and take more time for blood glucose to return to safe, normal levels. Unfortunately, the problem with glycemic load is that it isn't included on food labels and can be relatively difficult to fully comprehend. However, a good proxy for glycemic load that is on every food label is carbohydrate density. Carbohydrate density, or CD for short, is simply the amount of carbohydrate per 100 grams, which is printed on every nutrition label or on supermarket websites, making it easy to implement for everyone. For instance, if a food has 25 grams of carbohydrate per 100 grams, such as cooked rice, it has a CD of 25%. If a food has 5 grams of carbohydrate per 100 grams, such as strawberries, it has a CD of 5%. And when looking at foods in their natural form, it is uncommon to find foods that exceed a CD of approximately 25%, which complements the average carbohydrate consumption of traditional hunter-gatherer diets of 22%. With all of this in mind, an enlightening comparison to make is between the glycemic load and carbohydrate density of an Eat Well Guide breakfast and that of a PHC recommended breakfast. Evidently, a breakfast recommended by the Eat Well Guide in comparison to a PHC recommended breakfast has foods with much higher carbohydrate densities alongside a total glycemic load 46 times higher. This marked difference will raise blood glucose significantly more, as well as for longer, which in turn increases the risk of developing type 2 diabetes and obesity. And so, in light of this scientific evidence, the public health collaboration suggests that the UK should avoid foods that have a high carbohydrate density in order to focus on the consumption of foods and drinks that have carbohydrate density of less than 25%, as they are usually found in their natural form. So what's the alternative to current healthy eating guidelines? The two factors common to all traditional lifestyles in different populations around the world are that they ate real food and were active every day. With that in mind, we at the PHC created the Real Food Lifestyle. One of the most unique characteristics of this lifestyle is that it enables individual flexibility in eating all real foods, whereas current official advice has been one approach for all. Also, the Real Food Lifestyle is particularly apt as the UK is a multi-ethnic society with different ethnicities having specific dietary needs, as well as different cultural dietary habits. The Real Food Lifestyle switches the focus of healthy eating guidelines from maximum amounts, which can be perceived as targets to reach, to minimum intakes of essential nutrients with no upper limits. This approach ensures that everyone consumes the minimum intakes of essential nutrients and then allows for individual flexibility to maintain personal good health through real food, which is signified by the plus and minus signs on the diagram. In fact, the first ever dietary recommendation for the UK in 1950 from the British Medical Association was similar to this and advised that dietary fat intake should provide a minimum of 25% of daily calories with no upper limit. Although this may seem a little complex at first, the 9 words of common sense that everyone needs to remember are: eat real food, avoid fake food, be active every day. And as long as the principles of the real food lifestyle are followed and individuals are able to maintain personal good health, there should be no prejudice to whichever real foods enable someone to maintain personal good health, which is defined as: number 1, waist circumference less than 90 centimetres, that's 35.5 inches for men, and less than 80 centimetres, that's 31.5 inches for women. Number 2, fasting blood glucose less than 5.6. Number 3, blood pressure less than 140 for systolic and less than 90 for diastolic. Number 4, fasting triglycerides less than 1.7. And number 5, fasting HDL cholesterol greater than 1.03 for men and greater than 1.29 for women. If 3 or more out of the 5 are out of range, then this would mean that a person has metabolic syndrome and is no longer maintaining personal good health. If someone finds themselves no longer in personal good health, they should review and adjust their lifestyle in order to reobtain personal good health and should consider following the real food lifestyle for weight loss, which looks like this. And in accordance with the scientific evidence presented earlier, the real food lifestyle for weight loss primarily advises to follow a low-carb diet of real foods. This means that total carbohydrate intake should be reduced to less than 130 grams per day, made from non-starchy carbohydrates such as cauliflower, broccoli and courgettes, as well as high-fibre fruits such as raspberries, blackberries and avocado. Handing out this advice may seem daunting at first. However, there are an increasing amount of GPs who are recommending real food before drugs, such as Dr. David Unwin from the Norwood Surgery in Southport, who was awarded NHS Innovator of the Year 2016 for him and his team's real food approach to type 2 diabetes. The approach not only improved his patient's health dramatically, but his surgery is spending £45,000 per year less on drugs for type 2 diabetes compared to the average in his local clinical commissioning group area. If we replicated these results in all 9,400 surgeries across the UK, it would lead to savings over £400 million each year on drugs for diabetes alone. This approach would undoubtedly also have beneficial economic effects and health outcomes in respect to other conditions related to insulin resistance, such as non-alcoholic fatty liver disease, polycystic ovary syndrome, heart disease, some cancers, and Alzheimer's disease. Finally, for your information, you can download many free resources from the PHC websites, www.phcuk.org, such as our healthy eating guidelines and weight loss advice for the UK report, as well as our real food patient booklets, which contain easy to use meal examples and carbohydrate content guides. Thank you for listening, and if you do have any questions at all, please get in touch with us via the website.